In this PowerPoint, we are going to discuss few question and answer about the NCLEX licensing exam. This question and answer we collected from previous NCLEX board exam. So when we go through, we will try to make a note and we will review them. So we will not miss it. Here I want to tell you, we have a NCLEX preparatory program for 7 days. So within 7 days, we will review everything. Just 7 days review. And I like to student to take this challenge. So this question only about the adult health, particular cardiovascular system. The first question here, which sign and symptom accompany a diagnosis of pericarditis? So, the keyword is here pericarditis or pericarditis. So, what it is? Pericarditis basically inflammation of the pericardium. What is the pericardium? It is a thin membrane around the heart, right? When patient come to you with pericarditis, they have a chest pain. Because of inflammation, they have a sign and symptom of inflammation. What are the sign and symptoms of inflammation? Like chest pain, or patient have a shortness of breath, heart palpitation increase, low-grade fever, right? Sometimes cough or feeling sick. So here are the 4 options: fever, chest discomfort, elevated erythrocyte sedimentation rate. When any patient has an inflammation or infection, we have to say complete blood count. Maybe WBC go up, maybe ESR or erythrocyte sedimentation rate go up. Low urine output secondary to the left ventricular dysfunction, lethargy, anorexia, heart failure. Number 4, pitting edema, chest discomfort, and non-specific ST segment elevated. Out of 4, what is your choice? Definitely, number 4 is not an answer. Why? Because patient has a pericarditis. If patient has a severe heart failure, maybe pitting edema is common. But what else? Chest inflammation is common for pericarditis, but ST segment elevated, it is more common in case of myocardial infarction, not for pericarditis. Lethargy, anorexia, it is not a sign of pericarditis. Low urine output, secondary to left ventricular dysfunction. Pericarditis, it is the inflammation of outer layer of the heart, right? Or pericardium, not talking about the ventricular dysfunction. So when we make sure number 4, number 3, or number 2 is not an answer, what are the remaining? Remaining is only 1. Even I'm not sure, but still it is answer because I'm sure this is not an answer. As I told you, inflammation sign have a fever, pain, or chest discomfort, and elevate ESR. So what they said? So correct answer is A. So the classical sign and symptom of pericarditis include fever, also positional chest discomfort, non-specific, ST segment elevated, or elevated ESR or pericardial friction rub. So the low urine output secondary to the left ventricular dysfunction, lethargy, anorexia, heart failure, and pitting edema result from acute renal failure, kidney failure. So if you ask me how we diagnose the pericarditis, so if I talk about the diagnosis, always your provider may recommend one or more diagnostic test or procedure as part of an evaluation. So the treatment option for pericarditis, basically, if it is mild case, resolve on their own. If it is severe cases, may be treated using medication or surgical management. What next? A nurse is caring for a client experiencing dyspnea, depending edema, hepatomegaly, crackles, and jugular vein distension. What condition should the nurse suspect? Important. Let me tell you something. My patient has a dyspnea. Dyspnea means shortness of breath. Patient has a dependent edema, right? Maybe if patient have a edema in the face, we call facial edema. Facial edema more common if the kidney fail. If edema in the abdomen, we call ascites, and it is common in case of liver problem. If edema in the leg, we call pitting edema, and pitting edema is common when patient has a heart failure or heart problem. So facial edema, kidney problem, ascites or abdominal edema, liver problem, and pitting edema if patient has a heart problem. Important. My patient have a dyspnea, edema, hepatomegaly, means hepatic means liver, megaly means bigger in size. So patient has a liver enlargement. Because of fluid accumulate in the lungs, patient also added sound, crackles. Jugular vein, what we get in the neck, it is distension. So if my patient have all of this medical condition or presentation, right, what condition should I suspect? Is it pulmonary embolism? Is it heart fail? Is it cardiac tamponade? Or is it for tension pneumothorax? As a healthcare provider, we must know every medical terminology. The correct answer is here, it is heart failure, right? Heart failure patient can present with shortness of breath, can present with edema, hepatomegaly if patient has a right-sided heart failure, right? If your patient has a left-side heart failure, patient present with a lungs problem, right? Also, what condition I said? Here, I want to tell you, maybe you are lucky this question about the heart fail, but every student must know what are the signs, symptoms of the pulmonary embolism, what is cardiac tamponade, or what is pneumothorax. To be honest with you, to get your license, you do not need to be master in medical field or nursing science, but you have to know the basic, you have to know the medical terminologies. These simple things can help you to get your license. So if patient has a pulmonary embolism, it is a condition in which one of the pulmonary arteries in the lungs get blocked and may blood clot. In the lungs, we have a microcirculation. So when blood is passing through, blood clot can cause the blockading and patient present with some sign and symptom. Example, shortness of breath or chest pain, right? Or even cough. So at least we have to know what are the sign of pulmonary embolism. And even patient present with fever, excessive sweating, rapid or irregular heartbeat, palpitation, dizziness or tightness, right, in the chest. As I told you, we have to know the basic medical terminology from here. So if my patient has a cardiac tamponade, I'm sure so many good students here, they have enough knowledge, but they do not know what is cardiac tamponade. It's sounding so hard, but actually no, very easy. Cardiac tamponade, also known as pericardial tamponade. So it is actually compression of the heart due to the fluid buildup in the sac surrounding the heart. So when the cardiac sac is full of fluid, maybe accumulation of the fluid and causes the pressure over the heart, right? And if patient has a cardiac tamponade, most of them present with confusion, low blood pressure, shortness of breath, light headachenes, restlessness, sharp chest pain. Let me go. What is pneumothorax? It is called tension pneumothorax. I'm sure most of the students know what is pneumothorax, but few of them know what is tension pneumothorax, right? Pneumothorax means air inside the lungs. But what is tension? So tension pneumothorax is generally considered to be present when a pneumothorax means like primary spontaneous or secondary spontaneous or traumatic, lead to the significant impairment of respiration or blood circulation. So this causes a type of circulatory shock, and we call obstructive shock, important for our board exam. So basically, next one here, I said heart failure. Let me talk a little bit about the heart failure. So heart failure, a progressive heart disease that is affect the pumping action of the heart muscle. And this causes the fatigue, shortness of breath. So let me read the rationale from here. A client with heart failure has decreased the cardiac output caused by hearts, decrease the pumping abilities, right? And a buildup of fluid occurs and causing the dyspnea, depending edema. And as I told you, if right side heart failure, liver get involved, my legs get involved, inferior vena cava get involved. If my left side heart failure, my lungs get involved. Added sound like crackles supposed to be there. Jugular vein distension, all are the sign of heart failure. A client with pulmonary embolism experience acute shortness of breath, chlorotic chest pain, hemoptysis, and fever. A client with cardiac tamponade experience muffled heart sound, hypotension, elevated central venous pressure. A client with retention pneumothorax has a deviation of trachea and absence the breath sound on affected side, as well as dyspnea and jugular vein distension. What next? Next here, a nurse assisting has a finished the taking the routine vital sign of that client designed to her, assigned to her. While charting the letter in the shape, the nurse finds that the assistant documented a client blood pressure at 192 over 126 millimeter of mercury. So if I ask you, is it normal or abnormal? Definitely you will answer me, it is not normal. The systolic blood pressure more than upper normal limit, and diastolic blood pressure also more than upper normal limit. Means this patient is a hypertensive. So what are the most appropriate action for the nurse to take? Here, I want to tell you what are the key points. The key point, nursing assistant taking the routine vital sign of the client assigned for her. And this patient blood pressure is so high. So as a nurse manager or team leader, what you suggest to CNA or nursing assistant? Number one, ask the assist to take the client blood pressure again. Number two, take the blood pressure herself. Number three, assume the assist record the client blood pressure incorrectly. And number four, include the findings in her change of shift report, right? So the correct answer are take the blood pressure herself. So rational say the nurse is ultimately responsible for care she delegates to unlicensed personnel. The nurse should not assume the assist documentation is incorrect, and she should follow up on the care herself and take appropriate action. If the information is correct, the nurse should include it in her change of shift report. If the information is incorrect, the nurse should speak with assistant about the importance of accurate documentations. Uh, what next? A nurse is educating a client who at the risk for coronary artery disease, shortly called CAD, right? So coronary artery disease, the nurse tell the client that CAD has a risk factors. The risk factors can be controlled or modified, including. So in case of CAD, we have a two type of risk factor. Some risk factor is possible to modify, some risk factor are not possible to modify. What means you do not change it. First of all, let me tell you what is CAD. CAD or coronary artery disease, also known as coronary heart disease. It is a condition where the major blood vessels supplying the heart get narrow, and decrease the blood flow can cause the chest pain and shortness of breath. First of all, it is very important to know what are the basic sign symptoms of CAD. Patient may be present with angina or chest pain, shortness of breath, even heart attack is experienced if the coronary artery is completely blocked. Sometimes patient present with nausea, sweating. So we are talking about the factor that is causes the CAD, and which factor is you can change, and what risk factor you do not change, right? We call modifying, non-modifying factor. So first of all, here we said gender. Is it possible to change gender, men or female? It is possible. I'm not talking about the surgical operation because nowadays there's so many fancy materials. I'm not going that way, right? So gender is not possible to change. Obesity, definitely we can change it. Family history, is it possible to change? Definitely no. If my father has a coronary artery disease, it is chance I will chance to develop coronary heart disease. How I can change my genetics materials that I got from my father? So it is not possible to change. Smoking, definitely you can. So it is good 2 points, but this one not an answer. Inactivities. Yes, if I want, I can change. I can go for the walk. I can go for the running. I can go for the exercise. Stress. Is it possible to change? Yes. If you do not know how to deal with the stress can deal your life. It is good to kill the stress. You have to know how to deal with it. Gender, no. Gender not possible to change. But smoking, I can change, right? But because of this, it is not an answer. Obesity, yes, I can change it. If I want, I can reduce my body weight. If I want, I can change inactivities. I can change the modification of my diet, no fat diet, courage to intake fluid, discourage lipid containing food too much, fast food, avoid the salt containing food. And smoking, definitely, if I want, I can stop, right? This is a good choice. And stress, family history, no, not possible to change, right? So definitely, then we choose the answer only 3, which one can possible to modify, right? So rationale said the risk factor for coronary artery disease that can be controlled or modified include obesity, inactivity, diet, stress, and smoking. Gender and family history are the risk factor that cannot be controlled, right, my friend? Let me talk about the next question here. A nurse is preparing a client for cardiac catheterization. The nurse knows that she must provide which nursing intervention when the client returns to his room after the procedure. So key point is here, cardiac catheterization. Before to go next, I want to ask you, what is cardiac catheterization? So cardiac catheterization, also known as cardiac cath or heart cath, means catheterization. So cardiac catheterization involves insertion of a narrow tube into the heart through an artery to examine how well the heart is or how well the heart is functioning, right? So what is my expectation after the cardiac catheterization, and how I will prepare my patient? Very important to know. Even what are the risk factors of this? The nurse know that she must provide which nursing intervention when the client return to his room after procedure. Number one, withdraw analgesic for at least 6 hours after procedure. Number two, assess the puncture site frequently for hematoma formation or bleeding, and inform the client that she may experience the numbness or pain in the leg, and also restrict the fluid for 6 hours after the procedure. So this is which of the clients return his room after. So the nurse knows that she must provide which nursing intervention, right? So provide her a list of current medication to the doctor, or stop the taking medications such as blood thinner instruct. So first of all, I want to tell you something more. First, when a patient needs to go for cardiac catheterization, we have to check my patient take any kind of blood thinner or not, like warfarin or heparin. I have to stop it at least 7 days before cardiac catheterization. This question frequently asked in NCLEX board. Also, do not eat or drink anything at least 6 to 8 hours before the test, right? So again, I want to tell you, at least 6 to 8 hours before the procedure, not to drink or eat. And also tell the healthcare provider to check the allergic to anything such as iodine, latex, or any medication like penicillin, or any kind of X-ray drive. So the correct answer, the nurse know that she must provide which intervention when the return to the room after procedure. Assessment, the puncture site frequently, hematoma or hematoma formation or bleeding. Next question here, what mechanical device increase the coronary perfusion and cardiac output, or decrease myocardial workload and oxygen consumption in a client with a cardiogenic shock? So what is cardiogenic shock, if you ask me? So cardiogenic shock, a condition where the heart is unable to pump enough oxygen-rich blood to the body organs. And it causes the chest pain, or it causes the pain or discomfort the left arm, or also it causes the trouble breathing, sweating, fast or irregular heartbeat, right? I said cardiogenic shock. So first of all, my patient with a cardiogenic shock increase the coronary perfusion cardiac output. So cardiac output is the amount of the blood pumped by the heart muscle per minute, and is the mechanism where the blood flow around the body, especially providing the blood flow to the brain and other vital organ, right? So decrease the myocardial workload and oxygen consumption because of cardiogenic shock. There are 4 options: cardiac pacemaker, hypothermia or hyperthermia machine, defibrillator, or intra-aortic balloon pump. So which mechanical device increase? Which mechanical device? So here we are sitting to learn something new, what we do not know. It is not necessary every student must know every information or have to know every answer, right? So we learn in cardiogenic shock, we use intra-aortic balloon pump to increase the coronary perfusion. Let me read the rationale. The counter pulsations with an intra-aortic balloon pump may be indicated for temporary circulatory assistance in the client with cardiogenic shock. Cardiac pacemakers are used to maintain the heartbeat at a predetermined rate. So, cardiac pacemaker, not the answer. If my pulse rate is very slow, if my SNO does not produce the pulse rate, does not firing, does not produce electricity in my heart, you can put the pacemaker, right? Or we call pacemaker implantation, not a perfusion. So cardiac pacemaker used to maintain heartbeat at a predetermined rate. So you can determine how many beats per minute my heart can produce if my heart does not produce the pulses. It is the blessing of science, right? Hypothermia, hypothermia and hyperthermia mechanism used, machine are used to cool and warm the client with the abnormalities in temperature regulation. It is not related to cardiogenic shock. The defibrillator is commonly used to termination of life-threatening ventricular rhythm, right? Ventricular rhythm, not a cardiogenic shock. So next question here. A nurse is counseling a client about the risk factor for hypertension. Which risk factor should the nurse list for primary hypertension? Select all that apply. Right? So primary hypertension, my friend. First of all, obesity and diabetes mellitus, head injuries, right? And also stress, hormonal, contraceptives, high risks of sodium and saturated fat. Very interesting question. And we are going to learn something today. So the risk factor should the nurse list for primary hypertension. First of all, I have to know what is the primary hypertension and what are the secondary hypertension, right? So if I told you it is the type of high blood pressure or hypertension, the primary hypertension are more common and it is gradually in onset, usually affected after 40, and sign symptoms occur years after onset of hypertension. Usually patient has a strong family history and also I think can cause the premature atherosclerosis, right? But secondary hypertension less common or very dramatic in onset. Usually, patient is one first or second decade or fifth or sixth decade of their life. The secondary hypertension occur at, at the start of the high blood pressure. Family history may or may not be present. An underlying cause of secondary hypertension may be endocrine tumor, arterial stenosis, chronic contraceptive use, or chronic steroid use, right? So what factor? They said obesity, one of the risk factor for primary. Stress, one of the factor of primary. High intake of sodium or saturated fat, one of the cause of primary. But the disease, right, are the cause like hormonal contraceptives, endocrine tumor are the cause of secondary. Secondary hypertension, we differ from the usual type of high blood pressure, primary hypertension or essential hypertension, which is often referred to the simply as a high blood pressure. The primary hypertension has no clear cause and is thought to be the link to the genetic or poor diet control, lack of exercise, and obesity. So what are the rationale? Obesity, stress, high blood pressure or sodium intake or saturated fat intake, family history are all the risk factor for primary hypertension. Diabetes, head injury, hormonal contraceptives, or endocrine tumor are the risk factor for secondary hypertension. Very important for NCLEX board. Next question here. A physician ordered blood coagulation test to evaluate a client blood clotting abilities. The nurse knows that such tests are important in assessing the client at the risks of thrombi, such as those with a history of atrial fibrillation, right? What is atrial fibrillation? What is endocarditis? It is very important to know, at least the basic, right? Atrial fibrillation, basically a disease of the heart characterized by irregular or often faster heartbeat. And infective endocarditis means inflammation of the inner lining, the heart or chamber, or valves, usually caused by bacterial infection, right? Or prosthetic heart valves. So if in a valvular heart disease, we replace the artificial valves, or myocardial infarction. It is not infection, it is infarction, right? So it is actually the heart disease, right? So myocardial infarction or myocardial infarction, commonly known as heart attack, occur when the blood flow decreases or stop to the coronary artery of the heart and causing the damage of the heart muscle. The most common symptoms patient present with a chest pain or discomfort which may travel into the shoulder, left arm, back, or left side of the neck and jaw. Very common. Which stage determine the client response the oral anticoagulant drugs. So if patient have it, we will prescribe the blood thinner or anticoagulant. Bleeding time, platelet count, prothrombin time, and also partial thromboplastin time. So what is the marker? Answer is prothrombin time, right? So it is important to know what is the normal range of this. So a typical PT, shortly called prothrombin time or PT. So a typical PT result is 10 to 14. So normal range of PT is 10 to 14 seconds. So I want to request to my dear student, please give a focus on it. During the exam time, you in exam you are under stress, you forget your name. So I want to tell you, this is the time to give a focus. I wrote second, right? It is not a minute. So when NCLEX board give 10 to 14 minutes or 10 to 4 seconds, it can confuse, it make you confusion, right? So important, okay? Don't confuse, it should be C, okay? So 10 to, so normal prothrombin time is 10 to 14 seconds, right? When it is higher than that, means your blood is taking the longer than normal to clot and may be a sign of many medical conditions, or maybe sign of take the anticoagulant, right? So bleeding time or clotting disorder, another cause, or even lack of vitamin K. When lack of vitamin K increase this one. So PT determine the client response of oral anticoagulant therapy. The test measure the time required for fibrin clot to form a citrated plasma sample, follow addition of calcium ions and tissue thromboplastin, and compare this time with the fibrin clotting time in a control sample. The physician should adjust anticoagulant doses as needed to maintain PT at 1.5 to 2.5 times to control below. Maybe a question came in your mind. I said 10 to 14. Why it is look like this? 10 to 14 seconds is the normal range of prothrombin time. But when your patient under oral anticoagulant warfarin heparin, that times it is. So physician should adjust anticoagulant dose as needed to maintain PT 1.5 to 2.5 times the control values. When you are under anticoagulant, that times it is okay. Bleeding time indicate how long it takes for a small puncture wound to stop the bleeding. The platelet count refers the number of circulating platelet in venous or arterial blood. It is not related to this. PTT means partial thromboplastin time determine the effectiveness of heparin therapy and help the physician evaluate the bleeding tendencies. The physician diagnosed approximately 99% of bleeding disorder on basis of PT or PTT values. What next? Here, which complication does a third heart sound indicate? So we know we have a heart sound, right? So we have a common two heart sound, right? If I said, what are the common heart sound? We have a S1 and S2, but sometimes also the S3 and S4 are common. So anyway, here I'm talking about what are the common heart sound or what heart sound when produced. Anyway, let me go back. So which heart's third heart sound indicate? Ventricular dilatation, systemic hypertension, aortic valve malfunction, or increased arterial um, contraction, right? So the correct answer said here, ventricular dilatation. So if anybody have a ventricular dilatation, we can say the patient has a third heart sound. So basically, heart sound is two. One is S1, other is the S2, right? So S1, sometimes we call LUB, lub, and S2 we call say DUB, means dub, lub, dub, right? So, and but also, I mean, if you ask me why heart sound is produced, it is produced because of the aortic, pulmonary, tricuspid or mitral valve closure. Okay, but S3 heart sound is produced because of ventricular dilatations. So rapid filling of the ventricle causes the vasodilatation that cause auscultate as a S3. Increased atrial contraction or systemic hypertension can result in the fourth heart sound. The nurse heard aortic valve malfunction as a murmur, right? Murmur is a added sound. It is not the normal. What next? Next here. So yeah, so we done few of the question and answer for NCLEX board. I like to request you, please practice them as much possible. I strongly believe if you practice, it helps to get your license.